Good afternoon, everybody. Thanks for being in our nursing ground rounds. Welcome, Dr. Michael Goldfarb, and thank you for being with us today. My name is Lorena Telles. I work at La Cardio, and it's my pleasure to introduce to you our moderator for this event, Dr. Olga Cortez, Associate Researcher of the Department of Nursing and Research of La Cardio. Welcome, and thank you for moderating this event.
Lorena, muchas gracias. Buenas tardes a toda nuestra audiencia de La Cardio y otros hospitales de Bogotá y el resto de Colombia. Gracias por estar asistiendo a esta conferencia. Mi nombre es Olga Cortés, como lo dijo Lorena, estoy acompañando al doctor Goldfarb en esta conferencia. Recibimos todas las preguntas que tengan para él, lo tenemos en 15 minutos al final de esta conferencia. Algo muy importante que es claro que lo tengan en cuenta, les recordamos que al conectarse a esta conferencia, cada uno de ustedes autoriza el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la ley 1581 del 2012 y nuestra política de datos personales, la cual puede ser consultada en la página de la Cardio Infantil www.cardioinfantil.org. Como ustedes muy bien lo saben, y el doctor Goldfarb está de acuerdo, estamos grabando esta conferencia con fines académicos. El chat de preguntas va a estar abierta para que ustedes, por favor, nos anoten sus preguntas. No vamos a poder responderlas todas, pero pues trataremos de encontrar el mejor momento para responder las que podamos. En líneas generales, vamos a dar paso entonces a un poquito de contexto. Para empezar, vamos a decir que la movilización temprana en pacientes en cuidado intensivo es una intervención que parece que todo el mundo hace, pero y conocemos la importancia de la movilización temprana. Sin embargo, no todos los hospitales tienen un programa formal que debe ser implementado y ser parte de las prácticas seguras hospitalarias y de hospitales seguros a nivel no solamente nacional, sino a nivel mundial. Voy a pasar un poquito a inglés. In this way, Dr. Goldfarb will talk about early mobilization programs, and he is going to show us the importance of these kind of programs to be implemented in the hospitals. Dr. Goldfarb is an internist, cardiology, and researcher at McGill University in Montreal, Canada. He is also the director of the quality of care at US General Hospital. And it's nice to have you here, Dr. Goldfarb. Please go ahead with the conference.
Thank you very much, Olga, and thank you very much for inviting me. And I'm very excited to talk to you all about this subject that I think is very important and under-discussed. So today we're going to talk about early mobility. And we're going to talk in a few different settings. We'll talk about acute and critical care, but hospital-based early mobility and what that means. I have no conflicts of interest to declare relevant to this presentation. So this is the typical trajectory of a person when they come into the hospital. Prior to coming to the hospital, they may or may not have some existing functional impairment. It's more common to have existing functional impairment, for example, in people with chronic medical illness or older adults. Then when they get into the hospital, they're hit with an acute or critical illness. Then we strap them to the bed for a variety of reasons, which we'll discuss. And then they're in bed for a while. And this leads to muscle mass loss, and not just muscle mass loss, but rapidly. Within 24 hours, already a significant amount of muscle is being lost. And then when they leave the hospital, many of them have functional impairment. In critical care settings, up to 70% of older adults after they leave the hospital cannot return to the functional abilities they had prior to the hospital. And this can persist for a long period of time. So how often do they have these functional impairments? Well, this is a cohort of patients that we looked at in our cardiac intensive care unit. And it showed that at about 1/4 of patients, there was a functional impairment prior to coming into the hospital. This is something that could be different in different settings. A medical ICU, for example, may have sicker patients or obviously in different geographical regions may be different as well. But it just shows you that a good portion of the patients have some functional impairment prior to coming to the hospital. And then when you look at what their actual functional status is at the time of ICU admission, you find that nearly half of patients, due to their previous impairment, as well as their newfound critical illness or acute illness that has happened to them, nearly half of patients in our cohort had some functional impairment at the time of admission. And it's also seen in kind of regular hospital settings. So these are a couple of studies that look at hospital wards, and they found that at the time of the patients come in, up to half of hospitalized older adults have impaired mobility on admission. Now, I keep saying older adults, but it's true in many people who are not even considered older adults. Generally, people who are in their, middle ages may also have impaired mobility, because if they're sick enough to be in the hospital, they also probably have more likely to have comorbid illness compared to someone who's not in the hospital. So we looked at these two studies looking at hospitalized patients, and they found that there was a considerable amount of patients who had decreased mobility when they were in the hospital. So it's very prevalent. And some of the reasons for this bed rest when they get in the hospital is they're sick. They have an acute illness. We have to treat them. We have to give them intravenousous medications. We have to do certain procedures to them. So they need to stay in bed. And it's a complex care environment with lines and tubes, especially for example, in a critical care setting. And they often can't move because of the monitors that we need to put on them. As well as there's something else important to realize, that there's also a cultural or historical reason why patients are in bed. For example, in cardiology, until about 50 years ago, it was thought that moving a patient was very dangerous. The idea behind getting someone up and walking after, for example, a heart attack was something that could be extremely risky for that patient. The thought was a heart that was broken is the same as a broken bone. The same way you need a broken bone, you need to rest, and then it heals by itself with the proper care. So is a heart. You need to let it rest and heal on its own. And so that historical cultural approach in cardiology is pervasive for a large part until this day. Now we know, for example, in cardiology, after heart attacks, thanks to some of the work done by Dr. Cortez, that it's not a great idea to keep people lying in bed all day. And that's what we're going to discuss today, obviously. But it's still, that culture still is very pervasive in medicine, is the idea of that you need your rest in order to heal. You need to rest a lot of the time. And a lot of the reasons for bed rest is involuntary. So we tell patients they can't get up when they should be allowed to get up during those times. As I mentioned, the initial treatment of heart attacks was strict bed rest for up to 6 weeks. And this was cutting edge medical therapy about 70 years ago. And this culture has pervaded until today. And this just shows you that there's the recommendations for bed rest were getting decreased and decreased. So as the years passed, they went from 8 weeks of bed rest to 2 weeks of bed rest, and now the recommendations, but as I'll show you, it's safe to get people up as soon as possible after heart attacks. This is a study Dr. Cortez did where they show that the majority of time people spent in bed after a heart attack, and nearly half of patients after heart attack were there involuntarily, and very few patients walked within the first 48 hours. And many patients after a heart attack did not walk for 4 days after the event. So startling evidence from a modern contemporary cohort of patients that a lot of people are spending time in bed after a heart attack, for example, and are not walking. And this is a study that put accelerometers, so devices on people to look at what position they're in. And 70% of these heart failure patients spent their day lying in, 70% of the time they spent lying in bed. And only 4% of the time they spent standing or walking. And what was interesting is that it actually looked at the time that they spent lying in bed throughout their hospitalization. And even on hospitalization days 4, 5, 6, 7, when presumably their medical condition was stabilized, better controlled, and they were improving on a medical basis, they still spent the same time in bed, which is a little bit concerning. This is a study that looked at hospitalized patients, and they also found that 83% of the time they spent lying in bed. And as well as many of these patients had involuntary bed rest. And a lot of these times when they had involuntary bed rest, there was no apparent reason why they had bed rest. And as many of you know, there's a lot of complications that can have with bed rest. You can more likely to have blood clots, which can then cause pulmonary emboli. You can have heart problems. You can have muscle mass loss, skeletal muscle loss, and functional loss. You can have psychosocial impairments, depression, anxiety, skin breakdown, bladder and bowel problems. So, and these have all been shown in multiple studies that these are present invariably when you make someone lie in bed for a long time. And the proof is that when you have low mobility, people do worse. I apologize for the poor quality of the text of the slide, but just to highlight the key points is that on the left bars, when someone has lower mobility, which is the dark black column, they have a much higher rate of functional decline. And it's graded. So when someone has a higher mobility, which is the gray bar on the right of each column, they have a lower functional decline. Same as for institutionalization. So this is a requirement to go to kind of a long-term care facility after hospitalization or a rehabilitation center or inpatient rehabilitation. And the higher their mobility, the better, the less likely they are, and the lower their mobility, the more likely they are to require institutionalization. And there's also an association with death. So the less mobile they are, the more likely they are to die in hospital. And this also shows activities of daily living. So these are things like feeding, eating, the things that you need to do to survive, going from place to place. And so the lower mobility, the likely you are to have a decline in activities of daily living by the time of discharge. And also, that persists up to 1 month later in this study. So the lower mobility you have, the more likely you are to have poor outcomes, functional decline while in hospital. And this also shows that the lower your functional status is, the more likely you are to be readmitted. So as your FIM is a functional independence measure, so on the right side of the figure, the more independent you are, the less likely you are to be readmitted. On the left side, the less independent you are, the more likely you are to be readmitted. And it persists. So muscle weakness is very common at the time of discharge. And this persistence in muscle weakness persists in some studies up to 24 months. And I think it persists much longer. And the only reason they didn't capture it in studies like this is because they didn't watch people long enough. But clearly muscle weakness persists at 24 months. And what they interestingly found was, as the figure on the bottom showed, is that the duration of bed rest that patients had was associated with persistent muscle weakness at 24 months. So the longer they spent in bed, the more likely they were persistently weak at 24 months. So I outlined all the problems: bed rest, muscle weakness, decreased functional capabilities during hospitalization. And we know that they're associated with bad outcomes following hospital discharge. But the question is, can we improve these outcomes? So there may be different solutions, but one solution that's been studied and looked at is early progressive mobility. So what is it and why do we do it? So what is it? It's a structured progressive mobilization activities. And the key is early. So we do it when the patient is stable for you enough to do it. And this is much earlier than most people think. Really, the major criteria is cardiorespiratory stability is achieved. So the patient is not in an emergent state. They're in a state that they're stable enough medically that we can start moving with them, even if they're not completely medically optimized. So what's the purpose of it? One is we want to prevent the loss of muscle function. The point of this is not for them to gain muscle function. The point of them is to prevent losing that muscle function. We also want to help their mobility recovery, help them get back to their baseline before, or in sometimes even better than they were before. But most of the time, just help them get back to where they were before. We want to help them maintain or regain pre-hospital functional capabilities. And this is something that's not in the typical definition, but I put it there. Really the purpose of this is to get them out of bed, whether sitting, whether standing, whether walking, to do something other than lying in bed to prevent all those complications. So what's the evidence for it? First of all, is it safe? Because if it's not safe, no one's going to do it. If you're bringing patients out of bed or making them move and they're getting hurt or getting complications, you're not going to convince anyone to do it. But the evidence is that it's quite safe. So this is a systematic review of different studies that looked at mobilization. And they found that of almost 15,000 mobilization sessions, there was only 0.6% that had any type of adverse event that was clinically significant, but none impacted patient survival. And the most commonly what would happen were there was some transient physiologic changes, such as drop in blood pressure or increased respiratory rate or oxygen desaturation. And very importantly, one of the concerns is that there's going to have tubes or catheters or fallout or injuries to healthcare people that are helping the mobilization. And the truth is, there's just case reports of that. And this recent systematic review found very, very little evidence to support that this was a common occurrence. So do we have any observational evidence to support the effectiveness of early mobilization? Well, from the intensive care literature, the vast majority of literature has come. And what's some of the observational evidence? Well, there's some evidence that improves muscle strength and physical function. It can decrease delirium, decreases length of stay. It can improve post-hospital longer-term cognitive outcomes, as well as quality of life. And it can decrease the readmission rate, cost of care, and mortality. So as we know from observational data, it doesn't always necessarily translate to randomized data. But the randomized data in this case does support many of these issues. So there was a recent meta-analysis. In fact, there's actually been several meta-analyses on this, which all essentially choose the same papers and show the same things. There's 15, this meta-analysis looked at randomized controlled trials of early mobilization in the intensive care unit. And they ran almost 2,000 patients were included in 15 randomized studies. And most of the patients were quite sick. In these studies, they generally included patients who were mechanically ventilated or previously mechanically ventilated. And what they found was there was a decreased incidence of ICU acquired weakness. There was decreased hospital stay and ICU stay, improved physical function, improved disability scores, and decreasing of the deep vein thrombosis, ventilator-associated pneumonia, and pressure sores. They did not find any change in mortality or other outcomes such as hand grip strength. But I think most people would agree that what they did find was pretty worthwhile and pretty effective as a therapy. And so these findings and this randomized evidence in multiple trials has led critical care societies in particular to adopt this ACBD-EF care bundle, where E is for early mobility and exercise. Other care societies have also supported this as well in hospitalized and cardiac settings. But there are a number of barriers to mobilizing patients that we need to be aware of. Well, there's patient level barriers. So patients may be medically unstable. Patients may have tubes preventing them from mobilizing, mechanically ventilated. Patients may be physically restrained. There's a concern for, as we mentioned, dislodgement of devices. If a patient can't cooperate because of cognitive impairment, or is drowsy, or his pain is not controlled, or they're very difficult to mobilize due to practical considerations because of their weight, or if they're frail and weak, or if they're inadequate nutritional status, they may be more difficult to mobilize. There's also healthcare provider level barriers. There's limited staffing to routinely mobilize patients. So healthcare providers, as you are aware, are very busy, and they may not be able to mobilize patients at every opportunity. There's maybe a lack of coordination among providers, and there's also conflicting perceptions about the suitability of EM in some patients. So some people may feel that it's not safe to mobilize the patient. Others may feel. That goes back to the culture of that unit, of that place of care. And there's safety concerns. And providers may not have the training to perform early mobilization. These are all very important barriers to consider. And then there's also the institutional barriers. So lack of staffing, the equipment is not available. There may be orders. So this was something that we'll talk about later. There may be orders for bed rest. So when patients come in, the automatic order is bed rest unless specified elsewhere. And that can be passed from nursing shift to nursing shift, and patients the orders don't change, for example, until the following day or a couple of days later when it's noticed they're still in bed rest. Some centers need physicians to order mobilization. There may not be guidelines written or protocols in the center. There may be no space to do it. And there may be no one locally that's really championing it. So this is a study that we did that looked at some of these barriers, and we wanted nurses and physicians and physiotherapists to kind of tell them from their perspective, what's the problem? So the nurses listed a few. The most common concern over nurses, whether it was insufficient staffing, they didn't have enough resources. They felt that the patient level, such as patient stability, was one of the challenges, as well as it took a lot of time for them. Physicians felt like they had to order it, that they didn't have enough time to participate. And physiotherapists also said inadequate amount of staffing. But if you can see, the barriers that keep coming up time and time again are insufficient staff availability, as well as patient level barriers, the two key ones. So what are these nursing barriers? So we talked about nursing time that's not available. Well, there was one study that just watched nurses. To me, it would have been something that would be a little bit challenging to perform my job while someone was watching. But in this study, people watched the nurses, and they found that there was a number of opportunities to mobilize patients that were not done. And another word is physiotherapists. So physiotherapists are trained to assess the functional capabilities of patients and help them develop, maintain and improve their physical functioning. However, they're also not available all the time everywhere. I don't know about your healthcare system, but I can tell you that our healthcare system in Canada, in Montreal, where I practice in particular, doesn't have physiotherapists available all the time. And even when they are available, they don't always have the time to mobilize everyone. So for example, on weekends and holidays, nights, there's limited access to physiotherapists. And there is evidence that even when physiotherapists are available, it's very difficult to mobilize everyone because there's a lot of opportunities to move people, but the physiotherapists can't be everywhere. So physiotherapists are extremely important when designing program for early mobilization and as consultants during a program and for higher level functional needs. But physiotherapists aren't necessary for mobilizing every patient. So one of the issues that we wanted to do were address these barriers. So we looked at the existing mobilization protocols, and we thought that there were a lot of these barriers that were not addressed. For example, they were very strict on physiotherapist driven, and they didn't really include other people that could potentially be helpful in mobilization. And we felt that they were too burdensome on healthcare providers, on the healthcare team, and ultimately we didn't feel that they would be able to help as much as something that could be more practical and more generalizable to other settings. So what we did was we formed at our institution, we formed a multidisciplinary group that developed this early mobilization program to be more pragmatic, more practical in the implementation. And what we did was we made it easy to use by the bedside nurse. We made specific functional activities, which I'll show you in a second. And we brought family members in to help move the patients as well. And so our particular system, we create this level of function mobility scale, and it does two things. So typically, these mobilization programs do one or the other. They either describe what the current level of functional ability is, and then the physiotherapist, based on their knowledge, will then decide what to do, or they'll guide specific activities without really a functional assessment. So what we did is we combined them. So what's going to happen is the nurse will first determine the functional capability, and then will then guide activities based on that particular capability at that moment. And what does it look like? So this is our program. So at the top, you have exclusion criteria. So some things that create instability or levels that are not safe to mobilize patients, and they're listed at the top. And then we define the level of function, or LOF. And so these are defined in the middle in the text, and as well as below. And each level of function, as you can see, has a goal and has 3 specific activities. Now, it seems like a lot of text, but what we did is when we implemented it, it actually took very, very little time for nurses to get used to assigning the right level of function. And one of the reasons is the levels are quite clear. They're quite easy to differentiate and discriminate between the 2 levels, the different levels. So we found very little inter-observer variation, which means if 2 nurses looked at the patient, a very high percentage of the time, they would be able to assign the correct level of function, and they would be able to do it in a very short amount of time. And they would be able to do it typically with the usual assessment that they do. So it did not require any additional work from the nurses, because the nurses had already done the functional assessment. They were just assigning a level. And one of the really nice things about this, and we'll go through how it was done, is is a level of function assessment if you're wrong and off by 1 number, because generally people are not off by 2 numbers. If you're off by 1 level of function, it's not a permanent grade, a permanent level the patient's assigned to, because the next nursing shift, which may be 6 or 8 hours later, for example, they'll be assessed by a different nurse, and that different nurse may put the correct assignment at that time. So there's a number of factors built in to make sure that patients are assigned the right level of function and then get treated appropriately. So how does it look in actual practice? So the nurse performs the mobility assessment of what the patient was like prior to the hospital. What does that mean? It means they ask questions to the patient, or if the patient's unable to answer, to family member of what the patient was known to have. And that's important, because that's going to be our goal of how we get that patient back to what their pre-hospital functional status is by the time of discharge, or as close to it as possible. And then the nurse performs a mobility assessment of what that patient's functional status is at that time they come in, or within a short time of coming. The nurses then help the patient and family. They give them instructional booklets and links to online videos, which are freely available. And the nurse then does their mobility assessment. So they perform these 3 specific activities if there's no contraindication or exclusion for performing the mobilization. The nurses also have a role, like as I mentioned, to instruct the family members. So the nurse may show the family members how to do it, and then the family members on their own can do the mobility assessment, mobility activities. And what's nice is that often frees the nurse up and allows the nurse to do other things with their time. And it also allows the family member to participate. And engaging families in care is something that's not done enough. And family members are often looking to be involved and participate in care, but do not know how. So our experience as family members greatly appreciate the education on what to do and the opportunity to do it. So this is what the booklet looks like. In our setting, it's available in English and French, but obviously it can be translated into other languages such as Spanish. And it shows for the family member, what are the 3 levels of activity. This is the booklet. There's also a video with where these movements are acted out. So very easy for family members to follow the instructions. So what was our experience? So we wanted to actually put some numbers to show you all of the things that I'm saying. So a little bit worried about our hospital. I can tell you that the picture on the bottom here is taken on a much sunnier day than now. Right now it's snowing and very cold. But the hospital is an academic tertiary care center. The cardiac ICU where we tested it in is a 16-bed unit. It has both medical and cardiac surgery patients. And it, like most tertiary care centers, there's advanced cardiac and cardiovascular, non-cardiovascular care capabilities, such as advanced heart devices, mechanical ventilation, vasoactive medications, and so forth. We looked at the patient-nurse ratios. We had a multidisciplinary healthcare team involved. And we have, as I mentioned, very limited access to physiotherapists and occupational therapists on times that are not normal weekday daytimes. And the first thing we did was we asked nurses. So you have two groups of nurses. You have nurses that had used the scale for a while, and nurses that were just starting to use the scale. And we asked them if our mobility scale was appropriate or not. And the vast majority of them said it was the appropriate length. There wasn't additional items that were not necessary. They understood why we were doing it. The one difference, and it was clear, it was not ambiguous. The one difference was those who had experience doing it said it took less than 1 minute to assess the patient and kind of instruct them how to do the mobilization activities. The ones that didn't have experience thought it would take longer, which shows you there was a slight learning curve, but very quickly overcome. And what we found is we looked at 852 patients, and these patients have your typical cardiovascular diagnoses, the most common being acute coronary syndrome, such as heart attack, and the second most common is heart failure, and third most common is atrial fibrillation or other arrhythmias. And we found was, prior to hospital, their functional status of our group overall on average was quite good. Remember, the maximum score you could get is 5, and the overall average was 4.7. On admission, they had dropped to 3.3 of their functional status, which is kind of moderate functional impairment. And by discharge from the cardiac ICU, their functional status had improved. Now, this is not discharge from the hospital, because the patients are in the cardiac ICU for 2 days, 5 days, 8 days, or longer. They still may be in the hospital for several days or longer after. So their functional status may have continued to improve. And what we found is that before we actually implemented the program, of nearly half mobilization opportunities, no mobilization occurred. Whereas after we implemented it, there was near 100% mobilization during each mobilization opportunity. And a mobilization opportunity was defined as a nursing shift. So on a typical day, there was 2 nursing shifts, one in the morning, one in the afternoon. And what we found was nearly 90% of those possible activities were completed. As you mentioned, there are 3 mobility activities per mobilization opportunity, so 6 activities per day, and 90% were actually completed. So it was feasible to do it. And this just shows how very few mobilization opportunities were missed. But what we did find was that there were some people that had contraindication to mobilization, but 17 or 18% of patients had a contraindication to mobilization, which means they had one of those exclusion criteria. But in 99.6% of patients could eventually be mobilized either from the beginning or after a while. Because the nurse was reassessing the patient at each nursing shift, they were able to say, oh, this morning the patient could not be mobilized because of such and such reason. But the following nursing shift, they were able to mobilize the patient. And that's why almost every patient could eventually be mobilized. And we found, very similar to the literature, a 0.4% of clinically significant adverse events. And they were all minor. None of them had a major impact on clinical care. We found shortness of breath, high heart rate, chest discomfort, lightheadedness. We found no injuries to healthcare personnel, no patient falls, no tubular line dislodgements in 3,500 mobilization activities. This is another study where we also looked at frail versus non-frail. And what we found is frail patients, frailty is a condition most commonly associated with sarcopenia or low muscle mass and poor function. And as we can see, These were older adults. They were the same ages between the two groups, but the group that started at a functional status at 2.6 was a frail group, which meant they had a frailty score that was on average much higher, enough to consider them frail. And they started at a lower functional status and they dropped their functional status, but they also improved during their hospitalization, during the cardiac ICU visit. Similarly, the other group, the non-frail group, as well improved. However, as you can see, because the frail group started lower functional status, they also ended lower, but there was improvement in both groups. As we looked at the oldest of the old. So we looked at the patients 80 and older, and essentially it showed the same thing. So the pre-hospital functional status, as you can remember, it was actually lower than our average. Our overall average was 4.7, but in the oldest of the old, or the older groups, the functional status was lower at baseline. It dropped considerably on admission, but it started improving by the time they were discharged from the cardiac ICU. Most importantly, we also asked patients what they thought about the early mobilization. So we took a validated mobility survey and we adapted it for our use, and we asked 42 patients what they thought. And what we found is the vast majority of patients agreed or strongly agreed with the question. Mobilization should be done on a regular basis for patients in the cardiac ICU. As well as the majority agreed that mobilization helps my recovery in the cardiac ICU. And we asked family members what they thought. So we made a family member survey as well. The majority of family members being a spouse or partner, but also a lot of children of patients. And what we found was that family members are very interested in assisting with mobilization. The majority agreed or strongly agreed that they want to learn about it, and that they felt confident that they could help mobilize the family member or friend. And they wanted to be involved in helping mobilizing the family member or friend. But they had a lot of concerns. They weren't sure when it would be safe to mobilize my family or friend. And so we also asked nurses, physicians, and physiotherapists what they found about what their barriers were. And what we found is that physicians had the highest level of barriers, as seen by the highest score in the overall barrier score. And a lot of the barriers in physicians were on their knowledge about mobilization, their attitude, and their behavior. Unsurprisingly, physiotherapists had the lowest scores towards mobilization barriers, and nurses were in the middle. So this shows us that physicians are still lagging in terms of their acceptance of this technique, I guess we can call it. And physiotherapists obviously are kind of the most comfortable with this technique, unsurprisingly. Just to look at the different kind of subscales of the physician experience, we see that, for example, physicians felt education and training was by far their biggest barrier. And physicians felt the least comfortable with the family members being involved in care. So there is some work to be done in terms of helping the culture. So how can you implement a cardiovascular early mobility program in your intensive care unit? But this is really true for any acute care unit. One is you need a multidisciplinary team. You need to educate nurses and other healthcare providers that are going to provide the care, and you need to monitor adherence and reinforce. So step one is you really need other people on the multidisciplinary team. It's actually an interdisciplinary team. You need nurses, you need the nurse managers as well as the bedside nurse, and you need one nurse who's kind of a champion of the program. You need a physician who's going to be a champion of the program as well. You need input of physiotherapists and occupational therapists. Depending on the care environment, such as if it's an ICU setting, you may want a respiratory therapist involved. And it's very important to have patient and family representatives. I cannot tell you how much positive feedback and very useful suggestions were provided by patient and family representatives that helped us change the program into a patient and family oriented program. And At first, there'll need to be more meetings. There may be once or twice a week, or once a week, or once every couple of weeks at first, just to get everything set up over the period of a couple of months, finalize the team, identify what barriers are in your center, because every center has different barriers, and then choose which mobilization program to implement. And it may need to modify it based on what your needs are. So in our approach, we really put the nurse as the key factor of driving the mobilization. So it was a nurse, so I like to call it a nurse-driven, family-engaged, you can even say physician disassociated, because I really try to keep the physician out of it, because I thought that the physician involvement and physician orders were essentially a barrier to mobilization program. So educating the nurses were very important. So the nurses received kind of lunch and learn sessions back in the day when we were allowed to give lunch to people in the open environment, and maybe in your center it's gone back to that. But people having during a free moment 10-15-minute sessions where we go over mobilization and the different aspects of functional assessment and mobilization and how to instruct family members. We give some web-based case presentations to nurses they could do on their own time or during break time if they're interested, and we presented at grand rounds and presentations like I'm doing today to our institution to help change the culture and get everyone motivated and unified in this project. And the next thing is, once you implement it, you have to make sure that it's working. I can tell you that our nurse champion was very gung-ho and very motivated to make sure it was happening, and our mobilization was at 97% per opportunity, and she had to step away for a few months, and the mobilization went down to 70 or 80%, and she came back and it went back up to near 100%. So it's so important to make sure that you're auditing it every once in a while. It doesn't take a lot of time, because if you're recording this data, you just look at it and see what's going on, and make adjustments, especially if barriers happen. So what does this look like overall? This is basically a summary of what I just told you. And the key thing is this maintenance phase. So once it's in place, you just need to take a look back at what you're doing and make sure that it's still ongoing. These figures that I presented today are all available in some of the papers that have been published on the subject. And so what I like to say is bed rest often equals bad rest. For sure, there are some times when patients need to be in bed and shouldn't move, but other than when they're acutely ill or having a procedure done to them, they really should be out of the bed as much as possible. Early mobilization is really recommended not only by critical care societies, but other acute care societies as part of standard of care. Nurse-driven, physiotherapist-supported, family-engaged early mobility is safe, effective, and feasible. Our experience has been a very positive family nursing and experience. Physicians have been largely left out, and therefore aren't necessarily happy or are not unhappy about it, because they're blissfully unaware of what we're doing for the patient for the most part, although there are some that are interested, that are engaged in the program, but very few. And overall, implementing an early mobilization is feasible at any institution if there's a will of participants and of the institution, and it's a very pleasant experience for everyone. So I'm happy this is my team. Like I told you, this is a team approach. The members of the team have actually changed drastically since this picture was taken. As you can tell, this was taken prior to a time when people had to stay away from each other or wear masks. But as the team has changed, the goal has stayed the same. So it's really important that any new members of the team are integrated, and that the program continues to run smoothly. And I'm happy to answer any questions that you have. Thank you for your time.
Okay, thank you, Dr. Goldfarb. You have, in a very short time, condensed many information that for sure is very useful for us for the beginning in many hospitals, these kind of programs. We have some questions. I have so many of them. I have to select some of them, but what I would like to start with the first, which is you are also the director of the Quality of Care Committee at the US General Hospital. How do you integrate this program with other programs, and what outcomes you have into account to evaluate the useful or the evolution of the program in terms of patient impact?
That's a great question. And the key to quality of care is measurement. So we have to be measuring things. So that's what I tried to do is I showed you some of the data that we have, but the key thing is to find a way that's that the mobility and the performance is being measured. And so that was something that was very challenging in our center at first, because surprisingly, while we have a lot of computerized systems, a lot is being recorded on paper. And so it was it wasn't very challenging. It was somewhat challenging at first to convince people to, record the data in a way that we could then assess it. But what was nice about our particular program is the nurses really only had to write down, 3 numbers. They had to write down their functional status. They had to write down, which was a number, right? Number 4, for example. They had to write down how many activities they did, which is 0, 1, 2, or 3. They had a second number. And then they had to write if there was any exclusions. Well, the first thing they had to write was any exclusions, and then write what letter, A, B, C, D, or E. So they were writing 1 letter and 2 numbers. And then we collected that data, and it was very easy to analyze. So we sat amongst our group and analyzed it. And then when we had these were all kind of process measures, right? Are we doing the process of mobilization well? And then as a research level, I looked at the outcomes, but it could be very easily done as a quality level. And I initially presented as a quality thing as well. So as a quality thing is we're just presenting what is the association of our mobilization and our outcomes. And I didn't show it, but we actually have studies that show that there's a tremendous association between the implementation of our mobilization program and decreased readmission rates. And as well as that was the primary analysis. In the secondary analysis, there's also a suggestion of decreased, sorry, not readmission rate, I apologize, discharge to facility. So patients that got the early mobilization program after it was implemented compared to prior had much lower rate of discharge to a rehabilitation or long-term care facility, which is amazing. As a secondary outcome, we also found that there was decreased mortality. And that's something that was interesting, and that's something that we're exploring further in another analysis that should be coming out shortly. But the key to answer your question is you have to measure it and you have to report it. And reporting does not necessarily mean, to the government or even to the hospital. You have to report it within your department, within your division, and say, how can we improve it, and how are the outcomes? Could be more. You could do it on a fancier level and randomize a certain unit or certain part of the unit to mobilization and not, but I'm sure it changed.
Okay.
So I don't know if you can hear me. Yeah.
Yes, we can hear you. Yes. Well, we have another question, and Dr. Rincon, Monica Rincon said it's a very useful information and very interesting, but we don't have too much time. But for sure, we are going to have another time to hear you about that. I have 2 questions about patients that are under ECMO and ICU, and they have, for example, cannulated. They are cannulated. How do you perform the mobilization in these ECMO patients?
Yeah, so great question. There are ways to mobilize ECMO patients. There are a number of published case reports and case series on mobilization of ECMO patients. So I don't have the time to go into in depth, but if you search early mobilization in ECMO patients, you'll find there's actually very nicely described methods of mobilizing these ECMO patients.
Okay, they are included in the mobilization plan.
And not just ECMO, but also indwelling ventricular assist device.
Sorry, I can't hear you.
So, can you hear me now?
Yes, now,
okay.
Yes.
Okay, yeah. So, yeah, the question was, are they included in this mobilization program? The answer is they're not fully included. Extremely complex patients. The one thing I didn't mention, which is you bring up the point, is this plan is for about 95% of the patients. So there will be 5% of the patients that are so complex that this simple program won't work. And that's when you need specific protocols for those very complex patients. Absolutely. And those ones are in the literature, and those ones are very important to mobilize, because if you're on ECMO or a ventricular assist device that's going to be indwelling for a while, and the patient may need to be a candidate for an organ transplant, or there may be a prolonged critical care course, for example, then those patients need to be mobilized, because the functional capabilities and status of those patients are so important for how they do after, for example, the transplantation. But these are really complex advanced patients, and this program is really trying to get the vast majority of acute, hospitalized, and critical care patients who can be mobilized easily within any of these 5 levels.
Yes, thank you. I can see that many of the patients, or many of the program, is based in patients during ICU, after they have received any kind of procedure. And they follow the patient, I think, after ICU discharge. But some of the patients can be start this kind of programs before the surgery, before being submitted to surgery or transplant, to prevent complications in ICU and facilitate this mobilization in ICU after surgery?
Yeah, that's a great question, and there's an area of investigation called prehab. So pre as I mean before. So we think of rehab being after, but prehab is before. And yes. And so this prehab, there's a very important role for prehab potentially for those exact patients that you mentioned. There's not a very strong evidence base for that, but there are ongoing randomized trials that I'm aware of in Canada and elsewhere, looking at that exact question. What can we do to improve outcomes by getting them in a better functional status before? And that's an area of ongoing investigation.
I have another final, I think we don't have too much time, but nurses at pediatrics and physicians in ICU and pediatrics, they want to know if you have, you include this kind of population, or how they could do that.
Yeah, so pediatrics is, we're focused on adults, so over 18. There are definitely early mobilization programs for children. There's several of them that are published in the literature, and I advise to take a look at them specifically. One of the major differences with pediatrics is that the family is even more engaged in care. And so that's in pediatric medicine. There's even a stronger role for getting family members, helping moving their relatives. Kids don't necessarily have the same muscle breakdown as older adults, but definitely if there's critical illness or a younger patient with with significant comorbid disease, they're also at risk for tremendous post-hospital complications if we don't start moving them early. And really the goal is to overall identify whether it's pediatric or adult or elderly. The goal is just to identify as soon as possible when we can start moving them and start moving them.
I think this is one final question. It is, how do you include the family? They are trained, or they receive some training special some days before, or how do you do that?
Yeah, great question. So the family member is often present at the bedside. Often, and if they're not, we can call them to come in. And the family member receives the information booklet, leaflet that I showed you. They also get a link to online videos that we created. So we have a video for each level of function available in English and French, where we see a demonstration of someone performing them on a family member, on a patient. So the family members have the information booklet, they have the videos, and then the nurse tells them, say, your family member is level 3. So the activities they do and the ones they watch are the level 3 activities, and then they perform them. The nurse can watch them, making sure it's done properly, but they're usually pretty easy and self-explanatory. And then the family member does all the activities. The nurse is only responsible for the next shift, making sure that the family member hasn't progressed. And if they progressed, then the family member will be informed, and then we'll do the other activities appropriate for that level. So the family members is super simple for the family member.
Oh, that's fascinating. I think, Dr. Michael, thank you very much for the time. Unfortunately, is very short. We want to have many questions that solved with you today. For sure, you are going to be our guest very soon, because we need that. Thank you for sharing the knowledge about early mobilization and all your experience, because we saw many of your articles and research in the presentation. Congratulations. Thank you for being with us, and we hope we can share more time with you very soon. Thank you very much, and we don't have more time, unfortunately. Thank
you very much, everyone. Have a nice day.
For my questions, all of you. Thank you very much.